Good afternoon, everyone. Welcome to this hybrid meeting of the Angus Health and Social Care Partnership Integration Joint Board. I would remind all attendees that this meeting is being recorded and webcast live on the Council's YouTube channel. I've agreed to the attendance of some members remotely and would remind all remote attendees to mute their microphones when not speaking. For any members of the public watching, please note that all the public committee reports, including details of specific recommendations, are available on the Council's website. Thank you very much, and let's start the meeting. So if I pass over to Committee Clerk Liz, do you have apologies, please, Liz?
Thank you. We have apologies from Chris Boyle.
Thank you very much. And are there any declarations of interest or statements of transparency? No, I'm seeing shaking heads, so we'll go with that. Thank you very much, everyone. Okay, can we move on to item 3A, which is the minutes of the previous meeting. Are there any factual inaccuracies that need to be corrected in the minutes? Oh. David.
Thank you. It's not regarding any inaccuracy. It's a question regarding what I think is an omission. On page 10, under item 14, which was the discussion regarding the carer strategy, there is no reference in the minute to the discussion that took place regarding the Carers Act monies, which was quite a significant issue, and I think given that it was acknowledged there wasn't clear information about that, there was an undertaking to work on that and to revert. I think that should be added in. Thank you.
Thanks, David. Well done for highlighting that. We'll get them accommodated and signed off. If I could get guidance on how that sign off would be done.
I think we would just bring them back to the next meeting for approval.
That's super. Thanks very much. David, thanks. Okay, so that addition notwithstanding, is everything else accurate in the minutes? Are they then agreed? Yes, and we'll see them at the next meeting. Thank you very much. So let me get back to, and we're now on the action log, which is on page 13, and over to Jill.
Thank you, Chair. Members will see just two items on the action log, one of which is complete in relation to the annual work plan, and the revision of that is on today's agenda. The other outstanding action should probably be a red, actually, on reflection, given that it was June 24. But that has been outstanding for some time in relation to pharmacy and medicines governance. I do see that David Coulson is online. I don't know, David, if you wish to add anything to that in terms of any updates, or Sandy.
Okay, David, do you want to come in?
Yeah, so I don't have the points in front of me, Jill, but I'm happy to chase up the conversations that we've had previously. We are planning in February 2025 quite a large whole system conversation regarding medicines governance to ensure that our system is future proof. Now that will invites be sent to quite a considerable, large number of stakeholders across our system. As well, we'll be asking for SG representation and representation from the Scottish Medicines Consortium to support that conversation as well. And I think that's quite important to help us reset and to refresh where we are in Tayside going forwards.
Okay, thank you. So there's maybe a conversation around the timeline then on that particular action. So we'll see that at the next meeting.
Yeah, we can bring an update to the next meeting, and then potentially have a separate action to be able to close that off based on the conversation that David's talking about.
Okay. Any other questions on the action log, please? No, I think it does reflect there's been a lot of work going on clearing actions off the action log over the last few months, and it's good to see that come down. Thank you very much. Okay, So moving on to item 3C, it's the Chair's Assurance Report. So back to Jill again.
Thank you, Chair. So I'm not going to go through it in line by line. Everybody will have had the opportunity. This is our regular Chair's Assurance Report, following on from Strategic Planning Group, noting that we do have a strategic planning update for priority 2 also on the agenda. So happy to deflect any questions to Sandy, who did chair the meeting in September in my absence.
Very slickly handled there. Does anyone have any questions for Sandy on that paper? No, I'm not seeing anything. In that case, we will take it as noted. Thank you very much. And there's the action note attached to that. Just checking, no one has any questions on that. Oh, Andrew?
Thank you, Julian. Just one question on the action note, and it's really about membership of the strategic planning group as things are taken forward to step down the local implementation groups. I've got that wrong. Lakes, yeah. So are you refreshing or adding any extra members to this, or is it just a reduction in overall membership, given there are 4 members?
Okay. We will review the membership at the next meeting, Andrew.
Thanks very much. And over to the Chair's Assurance Report for Clinical Care and Professional Governance. So that's over to Alison. Thank you.
Thank you, Chair. So the Clinical Care and Professional Governance Group continues to meet monthly, and this is our regular assurance report to the IJB. You can see an update on the key risks that have been discussed, which include prescribing. There is an extensive work plan for prescribing. However, despite that, we're still not able to reduce the cost of prescribing due to a lot of factors that are out with our control, and we are looking at reviewing the mitigating actions for that. We continue to have an increase in items, and we are working on how we might address that with campaigns such as Value Your Medicines and a focus on polypharmacy throughout several services. Can't emphasise enough that this is everyone's responsibility. It's not solely a GP or a pharmacist issue, it is how we use medicines across our system. We've got a finance report on the agenda, so I'll not go into too much detail. An unmet need was the subject of quite a bit of consideration at a recent development day. I do think it's worth highlighting that we have been successful in NHS Tayside of appointing a full-time female forensic medical practitioner, who therefore means that we have a female sexual offences examiner now. So that's a great move forward from that legislative requirement. There'll be some work looking at how we work with our primary care out of hours colleagues to see whether we can build resilience into the availability of a woman, a female sexual offence examiner for people that request that, and so that is good news for us. Care home mention there of care home closure. We continue to monitor the care home situation in terms of the availability of care home beds in Angus. Happy to answer any questions.
Thank you very much, and it was really good to hear that about the forensic services. When I was visiting there last year anyway, that was a gap, so that's a really good development. And I wondered if I could be cheeky enough to ask David Coulson to come in here. David shared some really interesting information at I think it was a care governance meeting in NHS Tayside around the number of acute hospital admissions relating to polypharmacy. And I wondered if you would be able to give us a wee bit of narrative around that. I was quite taken aback at how big a factor that is. Thanks.
Thanks, Chair. I think you're making reference to the Dave Care audit our colleagues in the MFE team were doing. Now, right off the top of my head, I can't remember the numbers, so I don't want to be quoted on those. But what we do see is, as people get older and more frailer, there's an increased chance of hospital admission due to those medicines. We recently had a optimizing medicine conversation, it's a whole system conversation for which there's a sway which contains the detail. Be really keen for that sway to be shared with the IJB members to be able to see the outcomes of the conversation, but also the detail that you're referencing as well. Alison's absolutely right that this needs a big whole system conversation to ensure that we are using medicines safely across our system. And there's some great conversations at that whole system discussion that we had on medicine. So I'll get that shared with colleagues if that's okay, Chair.
Perfect. Thank you very much. Appreciate that. Thank you. Any questions? Martin Black.
Thanks, Chair. It's on page 22 and it's your financial management. And the lack of progress regarding the agreed plans. And then it's got the executive management team have struggled to deliver financial recovery plan. What support has been put in to enable that to progress?
Thank you, Martin. Very, very good question. So, in terms of overall support, as an exec management team, we continue to support the services. Part of the challenge has been balancing the demand that is coming through and how we balance the patient safety or the service user safety as part of how we deliver services, and that has had an impact on our ability to identify and actually achieve financial savings. There has been a lot of work through some of the work that Eunice has been leading around how we're working as a partnership and to identify any opportunities for efficiencies or improvements in the way that we can work in a different way together. But I mean, the support is there in terms of peer support for people, but the ability to do it based on the demand that's coming through every single service is really difficult whilst we're trying to maintain safety.
Sandy.
Yeah, thanks, Chair. Just picking up on that point. So the wording there is maybe too subtle, and it says the executive management team had struggled, and I think we should kind of note, and it goes on in the next paragraph to say, following the February position, following a renewed effort started in February 2024, as part of the strategic delivery plan, will help address gaps in the strategic plan as evidenced in IGB report 5224. You can't tell from this, but 5224 was a financial report to our last meeting, to the August IGB meeting, and that paper in August, which is obviously a few months on from the February position, had quite a few pages worth of financial plans set out in it. So that has been a challenge. It definitely has been a challenge. I want to say had. It is a continued challenge, but we have absolutely made progress, and that was all documented in that August paper. So I think that August paper is a real big step forward for us.
And Jill wants to come back in.
Thank you. It's just worth referencing a paper that was considered at the Audit Committee this morning in terms of the Finance and Performance Audit Scotland report on integration joint boards. So we're not alone in terms of the financial challenges that we face, and I'm sure colleagues across Scotland are having very similar discussions at their integration joint board meetings. So I think it is reflective of the current environment, the current landscape that we're working in, and who knows what today's budget will bring.
You went there. Well done. Okay. Any more questions on that paper? No. Okay. That's for noting, which is great. And next on to 3E, which is the Chair's Assurance Report from the Audit Committee. Just going to ask Andrew, who's right in front of me, to introduce it. Thanks, Andrew.
Thanks, Chair. It's a standard highlight of the last formal meeting we had on the 15th of August. Just a couple of points that we had a special meeting this morning, as Jill mentioned, to address two items that were carried forward from the August meeting. That was the follow-up actions, internal and external governance issues, and also the approval of the 23-24 audited accounts. So they've been approved as of this morning. So So that was basically the purpose of the meeting, the extra meeting today. So attached to this is the actual minutes of the August meeting, so I'm happy to answer any questions, or indeed Sandy, who wrote the report. Thank you.
Thank you very much, and it will be hopefully a comfort for you to know that Jill and I have both signed off those annual accounts, so our wee bit has been done already, so thank you. Sandy, do you have anything to pop in there? Okay, any questions on the Audit Committee minutes or to the Chair? No, thank you very much. Well, these were for noting. And if we can then move on to item 4, which is the Chief Officer update. Thank you.
Thank you, Chair. Again, a kind of regular report. Just like to bring a couple of sections to members' attention, particularly 3.1 and our delays in transfer of care across the system. Angus continues to perform very well in relation to their position in regards to individuals who are waiting for a transfer of care, whether that be from an acute hospital or community hospital back home. We have had a few challenging weeks recently, and I think that is reflective of just ongoing complexities within the community, and we're not alone across Scotland. We have seen quite a significant increase in delays and transfers of care, but we continue to work diligently to ensure we're doing the right thing for our patients who are waiting. Section 3.5 in relation to what matters to you, and members will be aware that we have mentioned this before. So Tommy Whitelaw has commenced his work with ourselves, and we've had a couple of sessions now. The feedback has been extremely positive. We have included our independent providers in that in terms of the care homes as well. So we just encourage, if any IGB members do want to join any session, then very, very welcome to do so. And that is part of the ongoing work to support staff health and well-being. Paragraph 3.9, just in relation to Consumer Scotland Act 2020, I think just to really pull out the good news story in that in terms of the review, and the Angus Health and Social Care Partnership has been held up as an area of, or a partnership of good practice in terms of how we do our impact assessment. So thanks to Morgan and all the work that she's put into that. I think it's a really good piece of work. We have one member of staff from the partnership who has been nominated for the Scotland's Health Award. And 3.12, just in relation to the visits, we've had a few visits over September and October, which have been really good, and I think people have enjoyed both going out, but actually seeing individuals from IGB and ourselves going out and speaking to staff. So again, if anybody does want to join any visits that are planned, or has any kind of desire to visit anywhere else, then let us know.
Thank you very much, Jill, and good luck to Fran. And actually, I think we need to get better at nominating our workforce for awards. So just hold that thought. I would really encourage that, because there is a lot of good stuff going on, and we want to see it recognised. It would be really good. And I think if anyone wants any discussion around that, then speak to Jill. That'd be super. Any questions for Jill? Sam?
Just to reiterate what Gillian said, the visits with Andrew and myself were very useful, and if people get the opportunity, please take them, because I think the staff were delighted to see us, which is good, and it wasn't just tokenism; it was genuine interest in what they do. Yeah? So thank you.
Thanks, Sam. Lois?
Yep, thanks, Julie. It was in relation to 3.7 and physical inactivity. I've previously kind of highlighted the barriers to physical participation across Angus, particularly in relation to access to and within our leisure facilities, such as misuse of disabled parking bays, inadequate adapted changing and equipment, facilities, pool temperatures, and the availability of space as well. These barriers impact on older people, people with health conditions and disabilities, and our young people. I know that this has been raised as well at partnership events, and I just wondered if there was an update on partnership work and any kind of improvements that kind of have been made on the back of this.
Thanks, Lois. Jill's going to pick that up.
Yeah, thank you, Councillor Speed. So, as you know, we're trying to work closely with our Angus Alive colleagues in terms of trying to break down some of those barriers and support individuals to have access. So, happy to pick up a conversation out with and share some of that. And I could make a point of including it in the next Chief Officer update for the next IGB.
Thank you.
Thanks very much. Any more questions on that paper? No, I'm not seeing any. That's for noting anyway. Okay, thanks very much. And if we can move on to 5, which is appointments. And just let me move on. So we're being asked to appoint one member of the IGB to the Audit Committee with effect from Friday. Review, reselect and reapprove the membership of the Audit Committee, minus Councillor Meehan, who's stepping off the IGB, and approving the appointment of Stephen White as Vice Chair of the IGB until the end of the year, at which point he will swap over with me and take over the Chair position. Does anyone have any questions around that or any nominations for the Audit Committee member? Andy.
Yeah, thanks, Chair. Yeah, regarding the nominations for the Audit Committee member, as many members all know of this committee, when we have a vacancy on the Audit Committee, we put out an email seeking volunteers. And we've done that, yeah, volunteers, that kind of volunteer in those inverted commas. This time we have got one of our members who's volunteered, and Chris has very helpfully volunteered to come onto the Audit Committee, so very grateful to Chris Schofield for doing that. So that's the nomination we'd like to put forward, Chair.
That's great, thank you very much. And do we need a seconder or anything, or are we quite happy just to agree by acclaim? Yes, get in quick, yes. Marvellous. That's great, thank you, Chris. I really enjoyed my time in the Audit Committee, hope you do too. And so that's item 1 sorted. Is everyone happy around recommendation 2 as described? Yes. And happy with the appointment of Steve as the Vice Chair. Steve, marvellous to have you as the Vice Chair. Thank you very much for that. So that's us covered off the recommendations on that paper, which is great. Thank you very much. That was quite easy. And item 6 now, the updated annual work plan, and that's on page 42. I think Jill's picking that up first.
Thank you, Chair. So again, in a regular report, members will see the addition in relation to the current position, and that was one of the action points from August IGB, and a question raised just around having transparency around any shifts or changes in terms of the timelines for reports coming to IGB. So we have gone back to April this year, and in future reports it will just be for the time period in between IGBs for relevant reports.
Thanks, Jill. And I just wanted to highlight just how thorough this work plan is and how busy it keeps people. And I'm very mindful if we ask for interim reports or anything, the impact that has on the work plan and officers' time. So as we picked up in a previous paper, maybe updates in the Chief Officer's report rather than full-blown papers might be a route to go, rather than creating a whole new reporting cycle for future reference. So if we can avoid doing that, and I include myself in that, I know people are interested in seeing things moving along, but we need to be mindful, particularly as we're going into the winter period, about capacity, given all the other demands on officer time. So with that note, Jill's wanting to come back in, and then if there are any questions, I'll pick that up after. Thanks.
And I've just spotted an anomaly in the paper. So in term on page 43, the Angus and Dundee Stroke Rehabilitation Pathway Review, the end column should say that that is included in Strategic Planning Priority 2 update. So updates in relation to that will come through around the progress, and if there's a specific report required, then that will come back individually. So apologies for that.
Thanks, Jill. Any questions for Jill on that work plan? David?
Just very briefly, Jill's actually answered one of my 2 questions. You saw me coming. Coming on that. And I was going to ask, with regard to the Day Opportunities Progress Report, there's reference to allowing time for engagement. And I just wonder if it's possible to get some substance, given it's still scheduled to come back in December, which is not very far away.
It was around the engagement with day providers at the moment, and along with some of the work that Hayley's been leading with some of the providers, and we felt that in terms of the timing for it coming back, we wanted to make sure that we were doing the appropriate level of engagement and involvement to be able to come back to the IJB with a robust, informed position around any proposals that we may bring back in relation to the development of the strategic framework. I don't know, Eunice, if you want to add anything, or Sally, from an engagement perspective.
No, I think we've covered all that. That's marvellous. Thank you very much. Okay, on that note then, we're asking to approve the updated work plan reporting schedule and acknowledge that it will be presented at each IGB meeting as a standing item, with my additional plea for not overburdening our colleagues. So thank you very much for that. And now, if Kirsty Lee is going to come up around the Chief Social Work Officer report. This will be the 3rd time I've seen this, so I will not be asking any questions. It's not that I am not interested. I've had plenty of opportunities so to do, and I know a number of others are in the same boat. So thank you for all the work on this, Kirsty, and we do appreciate the massive impact that the services under your remit have on our citizens. Thanks.
Thank you, Chair. And you literally have stolen my introduction, so forgive me for repeating myself. So I welcome the opportunity today to bring the Chief Social Work Officer report for 2023-24, my first as Angus Chief Social Work Officer. This report has been approved by the Family Education and Justice Committee and Angus Scrutiny and Audit, and I apologise for those members hearing this short presentation for the 3rd time. During the previous presentations, I've done this jointly with John Cooper, who unfortunately is absent today, but presenting jointly with his specifically appointed lead for social work from the partnership has been very well received and has given a strong message on social work leadership. Social work and social care have continued to face incredible challenges this year, and these challenges are experienced most profoundly by our workforce and the children, young people, families and vulnerable adults that we support. The report provides an overview of social work services, including the incredible range of provision from pre-birth to old age, from community-based to residential care, from support to protection and everything in between. There is much to celebrate in the social work services being delivered, including the rollout of integrated hubs for mental health and substance use, reduced hospital discharge times, excellent performance on community payback orders, and the introduction of a Tayside Bairns House. We also have high-quality fostering and adoption services, as reported through our recent inspection. But the challenges are clear to see throughout the report and affect all of our services. The socio-economic climate and the shifting demographic towards an ageing population has a significant impact on need and demand for our services, as reported through increased adult protection work and increased care at home needs. Changes in the balance of care and the escalating costs of care, particularly for complex care packages for children and adults with severe and enduring mental health and disabilities, puts pressure on budgets and makes it increasingly difficult for us to provide the type of care we would want to in our local communities. We recognise a significant reliance on informal care across a range of situations, including our kinship carers, caring for a loved one and young carers. The carer strategy for Angus is robust, and recognises the crucial role that unpaid carers play across the lifespan, as well as the support they need to be able to deliver this care. Difficulties in recruiting and retaining both qualified social workers and social care staff support to meet the range of community needs, support people in their own homes and keep children at home. This is a significant challenge for us all. Plans are in place across the partnership and Children, Families and Justice to address these issues, but they are complex and they're big strategic issues that require both national and local responses, with a need for leaders across Children, Families and Justice and Health and Social Care to work collaboratively. So I conclude the introduction by stating publicly sincere thanks to our social work workforce in Angus Council and Angus Health and Social Care Partnership. Through uncertainty, through challenges, when times are tough, there is a culture of support and care and firmly of putting the people of Angus first. And as Chief Social Work Officer, I greatly and genuinely appreciate that. I'm grateful for the significant support social work services receive in Angus from our leaders, our elected representatives, our staff, partners and the public, as without them we could not deliver the good outcomes described throughout this report. I trust you've had a chance to read the report and happy to take any questions, ably supported by some of my colleagues from the partnership. Thank you.
Kirsty, thank you very much, and I heartily endorse the thanks to the entire workforce within social work and social care in Angus. Does anyone have any questions for Kirsty or her colleagues? Martin.
On item 9, the public health implications, the levels of unmet need in Angus, what are the levels? Are they going up or are they going down? What are the unmet needs? What are the levels of unmet need? Are they going up or down? And it's nice to see that alcohol and mental health are put into the same category. And are we able to see the impact on mental health and recovery and substance use, or vice versa?
So I will attempt to give you a general introduction, and I'll see if there's any colleagues that want to come in specifically in around areas of substance use and mental health. But I think across a range of indicators we are seeing a growth in need. So certainly for the operational areas that I'm responsible for children and child protection, we are seeing increasing levels of business. So whilst our child protection data shows it's fairly stable, the number of referrals and the number of the referrals that come in that require a follow-up from social work has been growing steadily. Now, children are impacted by all of those factors that affect adults. So mental health, substance use, domestic abuse and poverty significantly impact the care that adults can deliver for children. So we certainly see a growth over a period of time, and we would class that as unmet need, because universal services have been unable to meet the needs of these families. They then need social work services. So it's quite a generic statement. It's difficult for me to go into all of the indicators. However, across a range of indicators, we see growth in referrals, adult support and protection referrals. What we don't see are areas where we can stop delivering things. So there isn't a commensurate decline in other areas of business. Everything appears to be growing. Colleagues from the partnership might want to add something specific about our recovery models for substance use, but certainly in children's services and social work services, we see a significant impact. Thank you.
So does that include vaping?
So vaping comes up through our Angus Integrated Children's Services Partnership. So it's not referenced in this report because it's not a risk factor that comes to social work as such. However, what we do know is, as reported through our schools and reported through communities, that vaping is a significant issue for children and young people. And public health data will perhaps better report on that. But so whilst it's not something that comes to the fore in social work services, we know it is a massively escalating area of concern in respect to young people's health.
And that's something that the communities team has been working with children and young people on in Angus, Martin. And there's obviously legislation coming through includes vaping in the tobacco legislation, and there is emerging data on the impact of vaping, particularly the disposable cheap ones, whereas it is recognised as a useful tool for helping people to stop smoking. The marketing and the pitching of these cheap products to children is a massive issue and getting worse. And while I've got the mic, I would encourage everyone to have a look at the Scottish Burden of Disease study, and there's a link to that on page 4 of the Chief Social Workers report. That gives you a really good picture across the whole of Scotland on what we're all dealing with poverty as an underlying public health issue. Thank you. Does anyone else want to come in on the MAT standards? Oh, well, can we finish? You can finish this question before we go on to Councillor Speed. Thanks.
Thank you, Martin. Just a couple of things to pick up on. So Angus continues to progress really well in terms of their MAT standards, and we are due to receive the ADP annual report in December, so there'll be more detailed information in that. In relation to the question around unmet need, on page 82 of today's paper, we do include a summary of that as part of another paper regarding our met and unmet needs. So as a 2 weeks ago, within Angus, we provided over 12,500 hours per week of individuals receiving care, and the number of hours that we were to get source 558. The chart on page 83 shows quite a significant increase, and that is following on from COVID as well. And just to pick up on that unmet need specifically around adults within the substance use team, that is included in the Chief Officer update in terms of the numbers specifically within that service with an unmet need, following on from a question from the last IJB. So we do have the data by specialty, and we do work with individual specialties as much as we can.
Thank you. Lois.
Yeah, thanks, Julie. Just let me flash up my notes. Page 14 of the report highlights that in May 2023, the bespoke residential house set up for a sibling group closed, with the remaining residents moving on to adult care provisions. Page 9 states that this year a suitable house was identified and procured, and work will progress next year to conclude the necessary internal adaptations. I'm just wondering, how was the residential house referenced on page 14 not utilised to meet this need, or converted to meet the continuing needs of existing service users transitioning, or indeed in helping bring other people home, closer to home?
Thank you for that. I'll try my best to answer that. So working backwards perhaps, so the procurement of a new residential house came through the agreement of Policy and Resources in December 2022, I think that's right, December 22, to provide capacity to look after 4 young people locally in Angus, and the business case was presented and accepted, and that then started a process of looking for a suitable property. So that property needed to meet a certain specification to meet the care needs of 4 young people and the staff team that care for them. In respect of whether the house that was decommissioned, that had provided very specific and bespoke care for some young people in Angus that was no longer required because of the change in needs and age of the particular people. I am not entirely sure how that was either discounted or fully considered. I can certainly check that and come back to you. Again, in respect to the other part of your question about how I guess what you're asking is how we've considered the needs, whether we could have taken that house on and done something differently with it. I think that's someone we could perhaps take off table and not for public discussion, but certainly happy to pick that up.
Okay, thank you.
Thank you.
And I've got a separate question on something else, a very brief one, if that's okay, Chair.
Very brief.
Yeah, very brief. It's just in terms of carers and carers assessments and the numbers, which really still seem pretty low in terms of carers going through the carer plan assessment to help meet their own needs. I just wondered why we're maybe not reaching out to more carers to ensure that their needs are being met, given that we pretty much know where the needs of the service user and loved one perhaps is. I just wondered if we're going to look at ways to maximise that resource.
Eunice is going to pick that up, Lewis.
Thank you. Thanks, Councillor Speed. So we are looking at making sure that all staff are aware of our legal responsibilities around carers. We had our carer strategy our last IGB, and in the Chief Social Work Officer report you'll see that there has been identification of carers, and particularly the growth of young carers, which has been very positive. And staff are well aware that we should be asking people if they want a carers assessment. Not everybody wants a carers assessment, but that is offered as part of our assessment process when service users come to the attention of the Health and Social Care Partnership. So I think it's an ongoing journey, it's a continual thing we are discussing. For example, this morning we were at a meeting, we were talking about the huge important role of carers and families and how we can really drive that forward, particularly around this current time with the pressures around winter and demand on services. So it is going to be a further driver that we're looking at to try and promote the role of carers and families as we go forward through this winter period. Thank you.
Thanks.
Okay, thank you very much. Any more questions from around the room? No? Well, the recommendation was that we discuss and endorse the contents of the Chief Social Work Officer annual report. And if everyone is happy to do that, then I think we've discharged that. And again, just to offer thanks to Kirsty and all who work in those services for supporting a lot of our most vulnerable people. And it does represent a huge proportion of the work that we do across Angus. So thank you, Kirsty. And it's over to Sandy now for the finance report, which is item 8 on page 50. Thanks very much.
Yeah, thanks, Chair. Good afternoon, everybody. And I, like a few people, feel I've travelled back in time in terms of technology as I've had to revert to paperwork today. So I have had to just move my notes around. So forgive me if I'm cross-referring. So this is our regular finance update for the committee. It includes a few important updates. I'll just try very briefly, Chair, to give you a few highlights before taking any questions. Sections 5.1 to 5.7 of the report set out where we are in terms of the financial perspectives of our NHS service delivery. It includes a number of references to things that we've seen before. We have noted things like pressures on psychiatric old age, out of hours, and prescribing budgets and services for that matter in previous reports. And we have noted previously that we have ongoing issues to resolve regarding our financial management of inpatient mental health services. In section 5.8, we describe the financial position regarding our adult social care delivery, again noting pressures that we've seen before in disability services, for example, pressures within community mental health services, but also some offsetting underspends in terms of care homes and some of the financial impact of unmet need, which again we have spoken about before. So they are some of the key factors in terms of the overall position, which I'll summarise in a second. Section 5.10 of the report talks about our position with respect to the financial plan, and we've included a new table that shows where we are with various elements of that. I think it's important to remember our progress with respect to delivering our financial plan, which includes items that we discussed at our August meeting, where there were a number of items there. It's going to evolve, it's going to take time, and our progress will be quite dynamic. And we know that although we're making progress on one or two things, we're also making not quite the progress we would have liked to. And I'm just using it as an example. In the table that you've got on page 55, table 3 of this report, we have got marked down as quite good progress regarding our community mental health services. But in terms of the dynamic environment that we're working in, the more up-to-date information that we have available to us since this report has moved that. It's maybe not quite as good as we thought when we first put this report together. And there are a number of dynamic factors that we're working with. We know, again, since we put this report together, that some significant extra inflationary pressures have come through on some national contracts. And we also know there's been further movement on some Scottish Government funding. None of those points, funnily enough, are going in our favour, and all are just incrementally working against this. But they do add up and they do have a cumulative effect. Saying that, in terms of the risks that we have seen regarding our financial plan, by the time we get to section 7.1 of the report, we are noting that we are now forecasting an underspend for this financial year of about £3.4 million. This is a movement from our last report to the IJB, and that mainly reflects the fact that we have got quite a lot more information regarding this financial year. The key points are listed in 7.2 under a series of bullet points. Some of these points are familiar to board members in terms of they are factors that have existed in previous years. What is helpful is that the second, the third and the fifth bullet point, and I wish now I'd number them, but the second, third and fifth bullet points all have a potentially long-term positive impact on our financial plan. So by the time we maybe next year financial plan, a multi-year plan, come back to the IGB, I'd hope that some of those factors can start building into that long-term financial plan, and that would be helpful. The other 2 points, Chair, just quickly to flag up. One is just again, I was mentioning risks. We are documenting our risks. They're all documented in Appendix 2. They are many, they are generally incoming. It is a volatile environment, you all know that, and that's why we keep documenting them. And the final point, Chair, is regarding Appendix 3, where we set out a proposal regarding reserves. And this is one of the key recommendations at the front of the report. This is under the section described as further reserves proposals. We are referencing here a reserve that's titled our Financial Planning Reserve for 24-25. It's one that we created at the end of the last financial year. We are keen to get this deployed, and we've set out some broad areas that we hope the committee would be supportive of deploying this funding against. And because we're quite keen to move this on quite quickly, the proposal that we put to the IJB is that working around those themes that are described on page 61, working around those themes that we asked the IJB today to devolve authority to the Chief Officer, Chief Finance Officer, in conjunction with the Chair, Vice Chair and voting members to develop and then action proposals around that set of ideas. That's not some of the things we've looked at in previous years. It's reflective of things that I've set out in the paper. We have to be considerate of the financial position of our two partners, NHS Tayside and Angus Council. We know that we have a relatively high level of reserves compared with other IJBs in Scotland already. We do have a contingency reserve. We have reserves to support our strategic commissioning plan. And of course, our job is to manage the long-term finances, and reserves would only ever provide short-term solutions to that. So hopefully that makes sense. Hopefully it feels a bit familiar to some of you. Chair, I'm happy to take any questions on that particular bit or the overall paper.
Thank you, Sandy. I've got Andrew first of all. Thanks.
Thanks, Chair. It's just a question on the table 3 on page 55 of the combined papers. The bottom row, where it's got projected percentage of planned interventions achieved for this and next year, it says 94%. But given that planned interventions are going to play a key role in the succeeding 2 financial years, is there any way of depicting how much is upcoming but not yet achieved, if you know what I mean? Because it all looks as if it's 94%, there's only 6% left to do the other 2 years, but clearly that's not the case. It's interpreting this picture is the question.
Yep.
Sorry, I didn't have that.
No. Okay. No. So I'll play that question back. So you're asking about the percentage represented at the bottom of page 55 in the table, table 3, and I'll have to have a look at the presentation of that ratio again. You know, if we're unsure about it. It's intended only to represent the progress in 24-25. So against the 1.4 target for 24-25, we're sitting at 1.3. What it doesn't show is, of course, the overall target. I can't remember the exact figure, but you'll remember a figure of about £10 million over 3 years. So £1.4 million of 10 million is about 14%. I haven't got that in, but if that's the kind of thing that would be helpful, I can start marking that in for future years. For future reports.
Thanks.
That's a good question. That's not one I would have thought to ask, so thanks very much. And Alison.
Yes, just a point really regarding the top of page 61, the proposals for the strategic reserve development. It does include prevention and proactive care alongside acting now to make things sustainable immediately over this winter. I just think that it's worth considering when we're looking at prevention and proactive care, what interventions can we make now that have the biggest impact on these other areas, such as the complex disability, and in particular around urgent care, frailty admissions, pulmonary rehab, and just to highlight that that is something very much to the forefront of our mind. What impact can we make in the next 3 to 6 months within prevention and proactive care that starts to have an impact on frailty admissions? We mentioned polypharmacy and admission to hospital, so I think it's just worth, within that strategic work, thinking around not just the things that help in 10, 15 years' time, but what helps 3, 6, 12 months' time.
Does anyone want to come back on that? I think that's absolutely the right approach, yes. Really pleased to see that. Any more questions? Oh, look.
Yeah, thanks, Julie. Yeah, probably just as a follow-up to what Alison's just said there, I think it would be good to see kind of the short-term impact, which is, you know, I think needed given the level of unmet need and that bit around prevention and being proactive. For me, I think the underspend is really concerning given that level of unmet need and the impact within our communities due to services. And I guess my question is, how would we kind of measure, you know, just as Alison has described, measure and monitor the impact of the proposals in terms of the reserves? But also, I wondered what the partnership were doing in terms of consultation with the public around budget setting. Angus Council have been consulting, and I just wondered what the partnership's plans were.
Sandy's going to come in.
Yep, thanks, Chair. So I'm going to partly come back to Alison's question in the first part of your comments there, Councillor Speed. So in terms of the shorter term, I think the short term, 3, 6, 9 months, we are currently in a partnership, as we just referenced, that is currently underspending. And if there were things that we needed to do in the short term, there is capacity in the in-year position to look at that. And I think that's how that would be best looked at, because that would be potentially an immediate thing that we could look at. And that's the kind of thing that could be taken forward through the management team. Sorry, Councillor Spear, I hope I'm going to cover all these points, but please just let me know if I haven't. A lot of the short-term spend, as you said, flagged up, it is a concern, and it is reflective in some instances of things like vacancies that we have in our services. And it is also reflective of things like the unmet need. Now, those are things that we have mentioned many times. That the unmet need issue is mentioned elsewhere in papers today. The workforce challenges would be mentioned elsewhere in papers today as well. So we are doing the solutions to some of these issues that would allow us to deploy more of the resource, spend a bit more of it, ensure it's kind of doing the right thing in the right system. A lot of the solutions to those will be described in these other papers, I hope. And I think that's how we would join those things up. You also mentioned how would we measure the impact of the deployment of the reserves. That's quite a difficult question, and what we have set out here is 4 broad areas of potential deployment. A lot of them would be reliant on specific plans being developed subsequently. The first one, which talks about deploying funds to support complex care disabilities and the capital funding associated with that. That would be essentially for us to create an earmark that allows plans to be actioned, but the detail would be in those plans, not in this paper. We're creating the mechanism the tool that the vehicle that allows something more detailed to happen. So in terms of measuring, that's where we would see that come through in the more detailed work. One or two of the proposals about supporting your whole system pressures, and I don't think our intention, it wouldn't be my intention for us as a board to be kind of micro looking at the measures of those. They're obviously whole management structures looking at that, whether it's an Angus Council or NHS Tayside or parts of other systems. And then we do have obviously an ability to monitor things that we put through our own strategic planning reserve. And that would absolutely be looked at with what I would hope would be the right level of scrutiny through the strategic planning group where that would happen. So although this paper hasn't intended to set out the measures of how we would get outputs from the deployment of the reserves, it's trying to put the reserves into places where they can be best managed and do things that would be for our specific good or a broader whole system good. So hopefully that feels okay, even though it's not a perfect answer to the question. And in terms of consultation regarding budget setting, one of the things that we have committed to, and you can't see it in these papers, but we have spoken about it at the Audit Committee, I think, this morning, is that when we next look at our biggest strategic plans, which would be the next strategic commissioning plan, which would be live from 2026, we would develop a consultation process that will happen in 2025, which is not that far away. And that will be, I think, our next big consultation exercise on our overall development of our plans. So that's not one specifically about an in-year budget position, but it is one that will be more about our broader deployment of our resources over the coming years. I hope that gives some helpful feedback on those points.
Yep. Thanks, Andy. I guess, yeah, my concern is just that money that is being proposed to go out to partners just becomes lost in the kind of the systems, the processes, the mechanisms, and doesn't end up filtering back down and ultimately having a direct impact on the people that need support. Thank you.
Yeah, thanks, Councillor. I'll just briefly come back on that because it's a perfectly relevant question and an observation that is worth hopefully replying to. So we know that various parts of our system are under pressure, and if we are able to put funding in to support those parts of the system that are under pressure, it may be, particularly if we're able to do this relatively quickly, it may allow people who are working in those systems to just make slightly different decisions. That's something that I think we'd all recognise is going to be quite hard for us to see exactly or directly, but it is something that I think would generally help those people in those systems, the ones that are making difficult decisions about future priorities and the way services develop. So that's how I feel this can help.
Thanks.
Thanks, Andy. Any more questions on the finance report? Nope, are we all okay on that? Just bear with me till I get to the recommendations again. Scroll back. Okay, so the recommendations on page 50 are three. So acknowledge the overall projected financial position of Angus IGB, accept and note the updated financial risk assessment in Appendix 2, and support the 4 reserves proposals as set out in Appendix 3 that we've just been discussing around the reserves. Are we all happy to accept those recommendations? I'm seeing lots of nods in the room, yes, and online. So thank you very much for that. That's fantastic. I'm particularly pleased to see the investment in prevention and proactive care there. That was great. Thank you, Sandy. Right, so it is now item 9, the strategic planning update, and that will be led by Jill. It's on page 62. And just a wee heads up, in half an hour, I'll take a wee comfort break for everyone, just so you know it's coming. Thank you.
Thank you, Chair. This is our third strategic planning update in the format that you've received today, focusing on individual priorities. So this is priority 2 in relation to care closer to home. a priority for the partnership to ensure that we can provide care for individuals as close to home as possible. There's a number of different areas within the action plan to support the progression to the overall improvements that we are making, but the report kind of details a level of reasonable assurance in relation to progress. Sandy's obviously picked up on some of the challenges that we have with some of the core services that do support individuals receive their care closer to home. So this is a big area of work. I think all three of our priorities kind of link together in some way, shape or form. So it is quite difficult to pull individual priorities out without making reference to other areas of practice. Sally's going to just take us through a couple of key points and then happy to take any questions.
Thank you. Yeah, just to highlight the fact that there are 21 actions within Priority 2, and we have already presented some of the progress in relation to carers, or unpaid carers in the strict carer strategy, which is aligned to this priority, and a number of separate areas within Priority 2 are coming to the IJB within the work plan. You'll have seen that. But just also to say that the majority of the actions are not due for completion until 25-26. So there is work, ongoing, and I hope you'll agree that there's, good progress being made. Just to highlight the indicators, we said all along that the local indicators will be evolving and work has been progressing, and so we have made some changes to the indicators, and we've provided an update on the local indicators. We've also brought to the attention of members the topic of homelessness, and so that we've provided a description of some of the actions and some of the progress that's been made in relation to that. So delighted to take any questions that you may have.
Thank you, Sally. Anyone in the room have any questions? Not seeing anything. Anyone online? Oh, sorry. David.
If I could just come back on the issue of the community stroke rehab pathway, which, as I understand it, is now being monitored within this. My question is about, which I raised when we first received the report, was about how we will monitor any care or impact of the initiative, and how we will, receive the monitoring.
Who is that? Eunice is going to pick that one up. Thanks, David.
Thank you.
Thank you, David. So in terms of monitoring any impact of care, I think we have a good overview of the impact on patients of Angus. There's a strong AHP workforce that supports the stroke pathway, and they are well cited on the needs of the patients that are requiring stroke rehabilitation. Thank you.
And Sally?
Also, just to mention, as you'll be aware, within the communication and engagement paper, we talk about care opinion, and just to highlight that a number of stories have come back from people who have experienced the community stroke rehabilitation service from Angus, and very positive stories about that.
That's great. I know we do have a fab team of AHPs to their credit. Lois?
Yeah, thank you. It's in relation to the homelessness agenda. I have huge concerns about people's pathways when they're, at risk and homeless, or even when they are indeed homeless. And this is something that impacts right across our community, from younger adults to older people even. And often people with significant kind of medical, health and social care issues who aren't being provided temporary accommodation, or indeed are being offered bed and breakfast accommodation or placements away from their family network of support. And it really concerns me, just some of the situations and experiences. We have older people that are sofa surfing, living out of bags, or even when they do get temporary accommodation, are often in accommodation for, you know, sometimes a number of years before they get a permanent home. I appreciate that this isn't just a kind of health and social care partnership problem, but I just wondered, from a health and social care partnership point of view, what is being done to address this and to protect some of our most vulnerable who are faced with these horrendous situations. I don't know if that's coming through in your stories, Sally, but it certainly is in my caseload.
Thanks, Lois. Jill?
Yeah, I think Councillor Speed, as a partnership, we're working closely with our housing colleagues and homelessness colleagues around how we can support individuals, obviously on a case-by-case basis, but we are part of the newly established, and the name's just gone out of my head, the Housing MOG, thank you. So that we have got a voice around that table from a health and social care partnership perspective as well, to support individual needs.
Thank you very much. Anyone got any more questions on this paper? No, I'm not seeing any. Oh, sorry, Martin.
Just on the homelessness, have there any directions been given on homelessness?
We haven't given a direction to date, Martin, around that.
Okay, so if there are no more questions, can I then go back to page 62 and ask if we can approve those recommendations as stated in the paper? Everyone? Oh, Lois,
Sorry, Julie. Yeah, just very quickly, if I may, before we move on, I just wondered, Jill's obviously talked about the link with partners with the council in terms of that MOG working group. And just on the back of the last question about, has there been any direction given? I just also wondered what discussions were being held at national level in terms of the housing shortage, which not just impacts on homelessness, but also kind of people's medical need for housing as well. Is there any kind of voice at the table at national level from the partnership?
There is the COSLA policy board around community wellbeing. That's where housing sits. And I know all the housing leads in the local authorities have a network there as well, separately to discuss the housing situation nationally. So yes.
So it is very much high on the agenda.
Yes, and there's Angus representation on all these policy boards. Okay.
Okay, thank you.
I've subbed twice for that policy board, and I know it is really prominent on the agenda, Lois. Okay.
Lois, it's just we are due to bring a report on the rapid rehousing progress report in February to the IGB in February, so we can pick up on some specifics to be included in that report as well, which may well end up in some kind of direction also.
Right, thanks very much. We're also being asked, as well as the recommendations, to accept the reasonable level of assurance. Is everyone happy to do that? Yes, I'm seeing lots of nods. Brilliant. Thank you very much indeed. And moving on now to item 10, which is the urgent and unscheduled care performance update report. And Jill, thanks.
Thank you, Chair. So I will attempt to talk to this paper. Dr Scott Jameson was going to be in attendance to talk to the paper, but he has been held up in practice today. So Alison may jump in from a clinical perspective. We felt it was important just to bring an update to IGB members just around some of the work that's going on regionally and locally around urgent and unscheduled care. We know that the challenges around urgent and unscheduled care and individuals being able to access care, whether that be from a health or a social care perspective, remains a challenge. So the report outlines the work that has been ongoing within the partnership. It demonstrates some data in terms of our emergency admissions and occupied bed days, which obviously link back to conversations around large hospital set aside. Alongside this, we do have a winter planning paper which is next on the agenda, and that's obviously a core part of urgent and unscheduled care provision across the patch. We have tried to include both medical and social care services, so individuals will see data relating to community land, care homes as well, etc. as part of this. I'm just going to invite both Alison and Chris may want to come in terms of urgent and unscheduled care as well. Alison, is there anything you want to bring?
Thanks, Jill. So,
excuse me, so I'm hearing a pinging. All right, okay, thank you. Thought I was going mad there.
Thank you. So, Angus has a long history of working very collaboratively when it comes to winter. We do have some particular challenges this year in relation to the finance available to support some of the actions that we usually are able to employ. However, I know that we are working hard to make sure that we have the right care in the right place. We knew this year we are going to be looking at the sustainability of primary care alongside the sustainability of all our teams, and that is really getting back to the principles of our enhanced community support model that has been so successful in Angus. It is looking at how we ensure that we have these resilient teams this winter, and key to this will be collaborative working at local level, escalating risks where we find them at local level, and the support for everybody to be working well together. And that applies at local level, and it applies as the interfaces with our hospital system. And I think we've got, well, I know that we've got the systems in place to support our staff, and I know that we'll be able to do our best for the population of Angus this winter. I'm happy to answer any particular questions. I know that we've got Lisa from Primary Care here as well, and our nursing colleagues.
Thank you. Offer Chris an opportunity to come in there.
Yeah, thanks. This is, as you say, a complex situation that the demand throughout urgent and scheduled care for everybody continues to increase. A lot of this is about getting access to the right care and the right people at the right time. And that may not be hospitals. It's all about it. There's a lot of it about needs. If we continue to push more people through hospitals, we create more dependency, and therefore we end up in a more difficult situation. So some thought about how we try and deliver that in a different way would be really, really helpful. But integration is critical to that.
Thank you. Lisa, did you want to contribute anything, or are you quite happy with your colleagues' bits? Could you put your mic on?
I think just picking up on Alison's point, and that will be followed up actually in our next paper about winter planning, is around the criticality of supporting general practice and that ECS model and working at a local level, because that's where the care is being delivered.
Just wondered if Andrew had anything to contribute there. No, you're quite happy.
Nothing specific, just to underline, I think the ECS model, I mean, that is we led the way in Angus with that, and I think this is a good opportunity to double down on that. I think the engagement from sort of health and care within those ECS discussions and planning for patients and proactive in a relatively short space of time is really positive and can avoid lots of admissions and increase spend and increase resource, and most importantly, is better for patients.
Thank you. Any more questions on Lewis?
Yeah, thank you. I kind of quite interested by this report. I think it's well set out, and I think what is really clear is just like the numbers, the figures, the statistics that we've maybe not seen in such detail before, which is really helpful. Probably relating back to my last kind of question around carers and the support they provide. I mean, when you see this, it also recognises, that carers are doing that bit of work. So we know the carers are out there, and surely there must be the mechanisms to make it easier. Not that providing them with a care plan and a budget for them necessarily is not going to be the answer to all our problems, but I think what it does do is help carers to feel recognised and valued within the vital role that they're playing. And I guess what my question is in relation to is just the unmet need or the transition when people are leaving hospital and where often a care home is the stepping stone before they go back home, or perhaps even is, you know, ultimately where they perhaps are moving on to. And I just wondered, given the situation with bed spaces in Angus, like whether we, you know, what do we foresee this winter? Are we kind of going to be in a really challenging position?
Thanks, Lois. I think we might pick up the last part of that on the paper around the winter plan.
Okay.
So if you're happy to park that, Jill will come up with respond to the earlier part of your question.
Okay.
Yeah. All right. She's saying, can we pick that up in the winter plan bit as well?
Yeah, that's fine.
That's fine. Good. I mean, what I got out of this paper was that a high degree of confidence that we've got the structures in place, you know, to deliver the services that we're needing. The governance around all of that is really sound. And I also, if you don't mind me reversing to the previous paper, Lois, on your point about housing, just quickly, housing comes up at Public Health Scotland a lot as a public health issue, so it is covered in lots of different areas, and they are joining up around that. So I just wanted to tuck that in for hopefully a bit of confidence for you. So aside from picking up the questions from Lois in the winter planning paper, Martin is looking like the last question here.
Just for clarification for me, Chair, on page 86, it's about spot purchase of interim beds.
Okay, so we'll probably just pick up. We can answer that quick, because that would be part of the discussion as the winter planning paper. But we can, given that we've had two questions, Chair, I'll just pick that up now if that's okay. So in terms of interim care home beds, as a partnership, we don't use a lot of interim care home beds. Alison's going to come in and share some of the work that's been going on around supporting that.
Yes, so interim beds are something that has been used across the country, whereby somebody that's ready to go home from hospital but where there's no care package goes into, the person can go into a care home. We have avoided that very heavily in Angus, because if someone goes into a care home when they should be in their own home, they decompensate, they might lose their confidence. That is different to where somebody might be going from hospital to respite because the carer cannot look after them at that time for a couple of weeks. That's different. Interim care, we tend to run around having one or two people across the whole of Angus at any one point, and that might be people who are waiting for something that's more complex, such as house adaptions. We really have avoided it, and that has set us in good stead, because as you can see from the data, the amount of care packages we're delivering is going up all the time. It goes along with our demographics. But despite having an increasingly elderly population, we're using less care home beds, and it's not because there's not been, we only have a few available, there's always a gap, but it's not because we haven't been investing in care. We've got the care side of things right, and that has been the absolute right model, because we can manage more people in their own home where they want to be, and it keeps our care home beds for when they're needed. So that is a part of our success, and that has led to some financial stability as well, because we're able to keep people at home and be less reliant on care homes. We don't have to pay the additional costs that come with having people in interim care. So I hope that answers the question, but it's something I'm really, quite pleased that we managed to go down that line in Angus.
Great, thank you. That was really helpful, Alison. Appreciate that. Kate. Yep.
Thank you. So I just wanted to just sort of be clear that we do have interim beds in our own local authority care home, and that's something that we've just redesignated in the last wee while. And the thinking around that was to have a focus around enablement within these beds, specifically for people that are trying to get out of hospital and getting back home. There's a focused sort of approach to people in these beds, and it's how we then move them back into their own communities. So we have made some redesign within our own services to allow to have interim beds, so we've got some control and some focus around enablement and allowing people to get back home. Thank you.
Thanks, Eunice. And Lois, you've got your hand up again.
Yeah, sorry, just to come back on that on the back of Alison, I think I appreciate and understand that the points that you're making in terms of, we want to get people home, not into care homes where they may become kind of dependent and it might take away their independence and the abilities that they do have. However, I'm also aware of situations on, number of occasions, lots of stories that have been shared about where, someone is discharged back home. They don't have the care package or support or the carer network in place, and they're left, in quite vulnerable situations, or indeed they return home, but they don't have the housing kind of adaptation, or the housing becomes an issue because of their ill health. There's mobility and physical barriers there, and again, they're often not able to access their most basic needs, such as showering and personal care in a safe way. So I can see the need for people want to return home, and many often do, and that choice should be respected. But there are many who actually, certainly in the feedback I've had, where they're crying out for help, or that safe space, that safe environment to meet their needs. How do we get that balance right? And is it about then saving money, or is it about making sure that we actually are able to properly look after people and uphold their needs?
So Jill's going to come in there, Lois.
Yeah, thanks, Councillor Speed. I think the priority around that is good discharge planning to support individuals to go home when it is safe to do so. And if that isn't their own home, then it is another area where we can provide safe care for that individual. I guess what I'm hearing for you is some potential examples that you have, and I would be happy to hear those examples out with the meeting, just to review if there are any learning points around discharge planning for those individuals.
Great. Yeah, I'd like to take you up on that. Thank you.
That's great. Thanks very much. So on that note, I think I'm going to go back to the recommendations and ask us to accept the two recommendations on page 76. And I think we have discharged our duties on that score. Okay, thank you very much. I think rather than start the winter plan, do you want to do it next and then have a break after that? Okay, is everyone okay with that? Just checking. Right, we'll take the winter planning update first, and then we will definitely have a comfort break thereafter. Thank you. Jill.
Thank you, Chair. It does kind of follow on from the urgent and unscheduled paper. So this paper outlines the Angus approach to winter. This year it picks up on a lot of the conversation that we've had just around the urgent and unscheduled care paper, particularly around the ECS model and the benefit that brings for individuals within locality areas. The approach in both Angus and NHS Tayside is absolutely in line with the four priorities that Scottish Government have published around the framework for winter, and they're detailed on page 90 of the report, with our specific areas of focus and actions under each priority. The NHS Tayside whole system winter plan, at the time of the submission of the papers for our IGB, wasn't available, hence the recommendation to approve that once the full document is submitted. But the Angus position is within the paper, and looking for endorsement around that.
Thank you, Jill. And I'm aware at a national level the amount of attention that is being paid to winter planning or surge planning right the year round, really. And there are dashboards that are available that are really helpful in terms of that operational management of flow in and out of the system. So that gives me that reasonable level of assurance as well. But if anyone has any questions, we'll pick up Lois's question first. Yeah.
The one around carers, Lois, in terms of, I mean, I think for carers and how we support carers and how we work with carers to support vulnerable individuals isn't just around winter. For us, we absolutely would aim to do that right throughout the year, and I think it goes back to the initial question a couple of papers ago around making sure that we do have carers assessments in place and carers identified to be able to provide a level of support. We know that winter does impact quite significantly on carer well-being as well, so it is really important that we can support carers maybe in a different way over winter, supporting their vaccinations, etc., to be able to continue to look after their loved ones. Don't know if you want to come back in.
Yeah, sorry. Yeah, just for clarity, it wasn't in relation to carers. Sorry, probably my two questions or points on the last agenda kind of rolled from one into the other, but it wasn't around the carers. And like you say, you would be looking to support them all year round, albeit I think the answer that you've given does provide reassurance over the winter period, which can be even more of an impact for carers and their loved ones. But no, it was actually around the potential increase in demand due to kind of increased hospital admissions and perhaps the need for that kind of care home bed space or respite place over the winter period. And given that we previously have reduced bed home spaces and shut down units previously, I just wondered whether the current numbers were going to be enough to perhaps support need that might arise that we're not aware of.
Yeah, no, apologies, Councillor Speed, for not picking up on the specific points. I think in terms of our care home availability internally, we do have the flexibility to use our beds to support individuals in the right way, and that might be respite, which we do have dedicated facilities for, but we have the ability to flex the numbers available around whether that be respite or whether we have to use those beds potentially as an interim move or potentially as a longer term, and we will base any decisions around that on the demand that's coming through the system at any one time to support the flow across the system, not just from an acute perspective but from community hospital perspective as well, and availability of support packages that we can increase within the community.
Thank you. I'm constantly referring carers, unpaid carers, to various sources of support as well. Chris first, and then Andrew. Thanks.
Thank you. I'm really supportive of the plan. I think it's really good. It's got that whole idea of prioritising care at home and making sure that we get the whole thing. The stability of the system from an acute perspective is reliant on upper quartile length of stay that we have in the hospital to allow us to move people through the system as quickly as possible. So minimising admissions by supporting care at home and being able to support rapid discharge with appropriate care is exactly what I think we would be very happy to see in NHS Tayside.
Thank you, Chris. I appreciate that. Andrew.
Thanks, Chair. It's not really a question on winter planning, but it's indirectly. I know we've got Category 1 responders later on in the agenda. I was just wondering how winter planning moves from winter planning to Category 1 responder stage. And in the instance of, say, a very heavy snowstorm or something like that, how adaptive is the workforce and how quickly can we switch from one to the other?
So we obviously last year, just over a year ago, had Storm Babette, that is a very massive example of how well our services swing into action in emergencies and crises. I remember saying at the time I was enormously proud of all parts of the system and the way that they coped with that awful situation. And we have a huge amount of experience and excellence in Angus and across Tayside, across all the public sector and the third sector around supporting people in situations like that. But Jill wants to come in too, and I see Lewis's hand too, so I haven't forgotten you.
Thanks. I think just to build on what Julie was saying there, I think as a partnership we have very responsive systems in place to be able to deal with whatever pressures that may arise. So a Category 1 incident, absolutely, Storm Babette was one of those incidents, and as a partnership and as a partner alongside our Angus Council colleagues and indeed NHS, we had really quick, robust structures to be able to respond to that. Our response will vary on whatever that incident is, and actually some of our structures we might put in place not necessarily for a Category 1 incident or an incident which requires a full Cat 1 response to that. So we do have adaptable and responsive, and hopefully in the paper that is coming on the agenda that does pick up on some of the learning from Storm Babette as well.
Thank you, Jill. Lewis.
It was just in relation to that and our responses and the workforce being able to kind of like flex and adapt and make best use of skills and areas of expertise. And I was recently on a visit through the partnership at one of our kind of supported living complexes in Montrose, and it was one where there had been a deregistration of the service, and it now has the concierge service, and so it was really nice to meet with kind of service users and families and staff. And one of the things that struck me was just around kind of staff's loyalty and dedication to stay within that setting, because they'd obviously received a downgrade in their pay. But what really got me thinking and struck me was that there is lots of unused skills and experiences that they have in terms of delivering health and social care that they're no longer using. And I just wondered, like, it just got me thinking, because I knew that the winter planning report was likely to be coming up. And I'm just, there must be occasions where, through the winter, through kind of the workforce challenges, staff, care providers not getting in to see people, or packages not being able to be put in place timely enough, that it did feel like there must be times where that is a waste of kind of human resource and those people's skills. And so I guess, my question around that is is there more we could do perhaps to better utilise our workforce, especially during times of emergency?
Yeah, thank you, Councillor Speeding. Without commenting on the specifics around the area you visited, I think that I would absolutely put my hand on heart and say that every single member of staff adapt in response to any incident to support individuals across the population of Angus and indeed our neighbouring areas. If they're not able to get into their own area or place of work, they will support as close to home or as close to where they can get to as possible. And we did have really good examples of that during Storm Babette, where individuals did undertake different roles because that's what they were able to do. We've got a really strong link with obviously Voluntary Action Angus and our own volunteers within the Health and Social Care Partnership as well to step up and support in those specific times of challenges. But happy to pick up a conversation if again you've got specific examples.
If we could, that would be great. Thank you.
I think to pick up on the discussion around visits, and this came up at NHS Tayside earlier in the week in a meeting. Sam's nodding because he was in the conversation. I think there needs to be a mechanism to pick up operational issues like that come out of meetings through the Chief Officer. rather than in an IGB meeting, so that things get picked up more quickly and more appropriately. So that, I think that would be helpful for anyone. Please do use that mechanism. Okay. So with that in mind, if I can move us to the recommendations on page 89, there's 6 there. We're being asked to approve the actions to support our winter planning in the report, and endorse and accept a reasonable level of assurance regarding our readiness for winter. And I think we've got quite a high degree of that. Support the whole system working, which seems obvious to me. It's every action has an equal and opposite reaction, so we need to work in tandem on that. And agree to endorse the NHS Tayside Winter Plan following circulation of the full document. That's on the agenda tomorrow, and we'll get that sent out once it's been approved. So just a quick email back to us would be helpful that you've seen it and accepted it. So thank you very much for that. We are now going to take a 10-minute recess. It is 15:35, so we'll see you at 15:45. Thank you.
Can we stop the live stream, please?
Welcome back, everyone. Apparently I went by the wrong clock, so sorry. There's 2 different times in the room and I went by the one on the wall. But we're all here. Thank you very much for returning. And that's us straight into item number 12, which is the primary update. I think, is Jill leading into it, or is straight into it? Is Lisa Prudham going to take us through this? Thank you.
Okay, thank you, Chair. So this is an update paper, so I won't go in all of the detail that's contained within it, as I'm sure you've had a chance to read it. But there are 1 or 2 things that I would wish to bring out. This paper is framed really around sustainability in GP and primary care, general practice. I can't get my words out. Sustainability. And I think there are 2 important things to note around GP sustainability. The government has two important pieces of legislation around helping to support general practice. These have been covered previously, but it's around the new GP contract and also about premises, because premises is a major factor influencing sustainability for practices. In terms of actually looking at sustainability as an issue, we have been working with colleagues across the NHS Tayside, primary care colleagues and colleagues within our other health and social care partnerships, looking at a very detailed survey for our practices, and we've done that. There are 2 complete surveys, both taking place in January, and an interim survey as well, recognising that this is quite a dynamic area in practices. Situations in practices change quite rapidly. But this information gives us quite a detailed picture of what's going on in practices, what the issues are for practices, and enables us to target our responses. So our full report from the last survey came out just around in the summertime. It obviously doesn't stop the fact that some practices still get into difficulties, and we all know the reasons why that is. There's an increasing demand on practices, and at the same time coupled with that challenge around workforce as well. So it's a perfect storm really for our general practices at the moment. But what this information does do is give us that kind of lever, an important lever to look at a more targeted approach, both with our PSIP work and with other things that we can do as a partnership. In terms of PSIP and the support that we have provided, I think the really key thing to emphasise again in this report is the work of our urgent care ANP team, because when things are difficult in practices and we know practices are struggling, that's one of the very concrete measures that we can do as a partnership, is to put in and kind of just alter who's looking after people in practices at that time, and just move our ANPs around a little bit. And we've committed and realigned quite a bit of our PSIP spend into that support, because it is a direct support to general practice, and it directly supports GPs themselves, because these nurses are able to undertake activities that actually would have been part of the doctor's workload. So I think the other thing that I do emphasise in the report is that we've committed as much as we can in terms of PSIP funding around that. And it does take a while to grow this workforce, and we've got the support of the lead nurse, and we have those nurses through in training, etc., until they become fully functioning ANPs. However, I think the challenge for us as a partnership and for us in primary care is perhaps finding more resource in order to build that team up further, because it is an absolute concrete measure that we can do to support practices. As I've said, nevertheless, we do sometimes see practices get into difficulty, and historically here in Angus we have had practices that have terminated their contracts. So we have two 2C practices, which are practices that are run by the Health Board, and a couple of years ago you'll recall that Freecombe Health Centre also closed down, and in that instance it was the best option was a dispersal of patients. We have a current situation with one of our practices, Annett Bank, who have handed back their contract and will close on the 29th of November. Now, as you can imagine, this is a really complex situation to work through. There aren't that many options in terms of how you provide general medical services to patients. As I said, the options are you can disperse patients, you can seek to find a new provider. We're currently working through exactly what that end outcome will be. This has been a very complex situation, and there will be a further report about that as that process kind of concludes. So it's just to draw your attention to that. In terms, as I've said, I've mentioned a few things in PSIP. In terms of premises, the work there is continuing, and premises are actually the main responsible body is NHS Tayside. We work alongside primary care, property colleagues, and there has been a lot of work that has been taking place over the last few months. However, I think I will emphasise that one of the difficulties, it's a challenge for NHS Tayside as well, because there is a lot to do in terms of the premises agenda. We know, for instance, that there are a lot of leases coming to the fore. And we have our priorities, and it's difficult for NHS Tayside as well in order to find capacity and finance, given the financial landscape that we're all operating in, to take that forward. So there's work going on around that as well. So they're the main things I wanted to emphasise from the report today, and happy to take any questions.
Thank you, Lisa. And Andrew would like to ask a question.
Thank you. Thanks for the report, Lisa. Very encouraging that the work's been done. My questions are really prompted by the visits I made recently to CTAC in White Hills, specifically for...
Your microphone's gone off.
It keeps going off. Sorry. Well, I did visit CTAC and MA, and spoke to people there, very, very warmly welcomed. But when the first changed the contract, there was an awful lot of initial resistance to ANPs taking roles from considerably traditionally, I want to see a doctor type of attitude. How is that playing out? Is that getting better, and our patients, our service users, accepting that offer more than they used to before? And if not, how are you kind of encouraging people to do it? Thank you.
So I think as we've seen this team grow, and that comes with it more acceptance, because people are more used to seeing and being treated by a different range of professionals, particularly around our AMPs. I think there's a growing confidence. I know certainly we don't hear any particular negative feedback from patients around that. And I know from a practice perspective, the work that the team are doing alongside our practices, they're a really welcome part of the primary care team. So I think I've got fairly good reassurance that I think this is the right thing to do, and I think patients are quite happy. Often we find that people just want to see somebody who's going to deal with them and not have delays, etc. So I don't think there's any evidence to suggest that people aren't happy with the service.
Thank you. And I think Andrew is going to come in there.
Thank you, and thank you, Lisa, for that reply. I'm just going to come in on that as well. I mean, I think there's always nervousness when you change the people and the structure and the shape of delivery of healthcare. And I think that was a natural nervousness, and that was our job to reassure the public that actually the service they're getting is as good, or actually in many cases better for that additional workforce. I think one of the key things in implementing ANPs, especially within general practices, is co-location where best you can, is that visible part of being a single team with the GP and ANP working hand in glove, if you like. Also, we've got the opportunity through some of our trainee ANPs coming in, being supported and mentored by GPs within practice. And again, patients see that, patients pick up on that in terms of the GP being available to step into consultations and support as well. So, and that word goes out, and it's just requires time. I think it also mirrors the increasing use of ANPs by secondary care colleagues as well. There's a lot of specialist clinics, you know, things like heart failure, specialist nurses, etc. Just as the first one that came to my head, so apologies to all the other specialist nursing teams that are out there. But you know, our patients and our public are getting used to that as a service. So I don't know whether it's possible. I was putting my hand up for other comments on the paper, if that's all right.
Just you crack on.
Okay.
Well, you've got the mic.
So I just wanted to pick up. There's one element in here that is, I'm afraid, factually inaccurate, I believe. It says, by law, everyone must be registered with a practice. The law is that everyone must be able to register with a practice. You know, you can choose as a member of the public not to register with the public with a practice if you choose. So, and I think that is an important distinction. So, and the other sort of thing I just asked for, it's the second line of the Annett Bank paragraph on the same page, page 99, that it says, it's the first line, currently a fourth practice, Angus practice, has handed back its contract. I think it needs given notice to hand back contract, because the second paragraph then gives the date that will happen. The only other thing is just above the Annett Bank thing, there's a lot of talk in there in terms of the quality of care being provided and that being poorer in 2C practices.
Actually, I don't think that, and I think there is evidence to suggest that in the early days, because of those challenges around actually getting staff in to work in them, there are poorer outcomes. However, I wouldn't wish to give the impression that that is, you know, that remains the case around our 2C practices at all in any shape or form.
Yeah, I think that is my caution there, is just that potentially, depending on how you choose to read it, could indicate that the staff are providing a lower quality care, as opposed to actually the lack of staff is what results in the potential lower quality care due to lack of access. So I think just emphasising the fact that actually our teams, our staff that are in 2C practices are still providing as very high quality care and excellent care to the best of their abilities.
Yeah, thank you for that comment, because that really was not my intention at all. Thank you.
Absolutely, and point made and received. So I've got Tina in the room, and then Nicola online. I'll be with you in a minute.
Hello, it was just for clarity for members. In terms of the recommendation number 2, approve the delegation of authority to the IGB's Chief Officer, Clinical Director, Chief Finance Officer in conjunction with the IGB Chair and Vice Chair and NHS Tayside Operational Medical Director for Primary Care to develop action plans to deliver general medical services. And in the body of the report, and it's just a nuance, but I think it's an important one to pick up so members of the IGB are sure as to what they're making a determination about. This was to develop and action plans for the delivery of general medical services. So I just wonder, just before we get into determination, whether clarity can be drawn around the terms of the recommendation for members.
Right, so actually things have moved on since this paper was written, and what we're going to have to do now is, rather than leave it to the chair and vice chair, there's going to be a special IGB called next week on November 6th at 9 AM. That should be 7, sorry, crikey. I'm having diary mayhem as it is. And it's online only. It should be a very short meeting. But there will be a decision to be made that wasn't ready for today. Which is why we're having to call a special meeting. So that will be in your diaries. So that is slightly different to that recommendation.
So will the recommendation be being deferred until the special meeting next week, just for clarity?
Yeah. Yes, happy with that. Okay. So thanks for that. I was reading it in the paragraph and thinking, it's moved on now. So we're happy with that. Okay. Nicola next, and then I think Alison in the room. Did you have your hand up there? Yeah.
Thank you very much. So for anyone in the room that doesn't know me, I'm Nick Richardson, Director of Allied Health Professions in Tayside, and I'm here for this is my first meeting here as one of your professional advisors. So just wanted to draw people's attention to the part on page 101 that talks about the implementation of a test for occupational therapy in primary care. I just wanted to pass on my massive congratulations to Angus for taking this step and being the first area in Tayside to bring forward this test. There is significant evidence across other areas in Scotland of huge impact to both patient experience, patient outcomes and GP capacity. So it's phenomenal and really, really brilliant that this has been taken forward as a test in Angus. So I just wanted that recognised. Thanks.
Thank you, Nicola, and thanks for coming along to your first meeting. It's great to have you on board. Big fan of AHPs here, and also an honorary nurse from NHS 24 Days, just for the record, okay? Alison.
Thank you, Chair. I just had a few points around primary care sustainability and the relationship with urgent care, because I think it's important to note that we are in a position where we are building for the future here. We're not just dealing with the here and now. We've talked a lot about urgent care, but it is how we develop for the future. And when we think of our advanced nurse urgent care practitioners, I think we have 7.6 full-time equivalents, my latest information, and many of them are trainees, and they are only in 3 of the localities of Angus. So it's work in progress, and I wouldn't want anybody to think that we've got one solution in Angus that's going to fix things this winter. It really has to be that collaboration I meant earlier. I think it's important to note that these are great green shoots of how we're improving, but this is we're no means there yet. There's a lot of work to do. I think regarding the user acceptability of general practice, seeing people that aren't doctors, I think that's coming, and I think we see in our care and experience surveys, the national surveys, that where practices are struggling, maybe their experiences drop, but then you see as they improve and change models, the feedback, it doesn't come up right away, because people need to adapt and get used to it. But for me, the proof is in the pudding. If they have a great experience from general practice with new ways of working, they'll stick with it. And we can see some of the care opinion feedback in our 2C practice in Brecon, for example, but also in Abbey, around some of our newer practitioners is excellent and really great to see. So it is about just having a little bit of patience, watching the data, quality improvement approach, and we'll get there. It's just there's not going to be a magic here. It's going to take time, but we're getting there, and we need to really work on. Nick there's mentioned around the AHP opportunities, mentioned nursing. There are other professionals as well, and really keep that quality improvement, gradual iterative process around professions, but also in each geographical area, collaborative working, and we'll get there. It's just a bit of patience sometimes.
Thanks, Alison. I've got Lois next.
Yeah, it was, certainly not questioning the kind of quality of care, but more just, as you say, that kind of change in service and the way that the services are being delivered within GP practices. And some of the feedback I've had from patients is that they're maybe going through the triage system, and maybe, you know, they're having like over the phone consultation, or they're being asked to maybe send pictures in terms of what their kind of health concern or ailment is. And sometimes they're maybe getting kind of maybe wrongly prescribed or wrongly diagnosed before they eventually get to the root of the problem, which often comes when they eventually get that face-to-face consultation with their GP or nurse practitioner. And I just wondered, is that something that's kind of monitored and measured in terms of kind of that cycle that sometimes patients go through, albeit it maybe isn't a lot. I don't know, maybe you'll be able to help. Maybe it's a myth, maybe that's not the case, but that certainly comes through in some of the feedback I receive.
Thanks, Lois. Alison's going to answer that.
So, Lois, I think we can be very honest here that that is the experience of some people who attend general practice or contact general practice. The reality is that the sustainability of primary care is our biggest risk, and we have to be honest and transparent about that. It's a shame Scott isn't here, Scott Jamieson, because he has done a lot of work nationally around the Scottish National Access Principles, I think I've got it right there, that set out the principles for people when they access general practice. And it is about prioritising urgent care. And the reality is that sometimes we are managing care over the telephone, if we're not able to give that experience that people may prefer. And that has got to be because we have to think around patient safety, the whole system working. But I can give you every assurance that while we are focusing on these access principles, there is also a tandem piece of work around prevention and proactive care, building the professionals to offer people good experiences and the right thing for their care, thinking around how people can support their own health. So we've got extensive programmes of work, and as I said, be very open and honest, Lois, that is the experience of people, acknowledge that, but we are doing everything across every geographical area, every practice, to turn that around. And going back to the question that Andrew quite rightly came in and said the experience in 2C practice is not necessarily lower quality. This is about quality improvement across all our practices. We can always improve, and that is definitely the approach that we are aiming to take. We're at different stages of different areas, and it's about how do we support everybody to get up where we need to be.
Thank you, Alison. And Jill and I have just had a little confab there around a potential to have a development session around primary care and the issues there, and in terms of some of the great and innovation that's on the go as well, just to get a really balanced picture. So we do have some sessions coming up that will need to be done, given that we've got a new, some new people around the table, but that I think is going to be a really helpful one for people. So that will allow us to get into a deeper discussion there. Andrew has his hand up.
Thank you, Chair. Certainly support everything that Alison just said in response to Councillor Speed. I think a couple of things on sort of mechanisms of access to practice. I think there has been a huge amount of innovation, which is positive innovation as well, and perhaps, as always, sometimes the stories that come to us aren't always sort of completely sort of, they're slightly biased, because if you have an incredibly bad experience or an incredibly good experience, you're more likely to talk about that. So certainly I would hope that every practice has mechanisms to deal with episodes where you were suggesting there that wrong diagnosis or inappropriate treatment. All practices have mechanisms to undertake significant event and case reviews as part of their quality management and assurance processes within practices. So I would hope, certainly if there are any examples of that, certainly if patients are coming to yourself, that you would encourage them to go to their practice and to raise that as a concern, because practices are always keen to learn. But equally, telephone consultations and sending in pictures and things can actually be hugely helpful, especially for those who are working, struggle to get into the practice and actually want these different mechanisms of consultation and actually find it beneficial to them. So actually having that wide range of access mechanisms is really important to support patients. Just one other thing I forgot to mention, and perhaps it's just the way it comes across in the paper, item 12, communication engagement. I actually think there should always be an element, especially when we're talking about changing the models of care, access, sustainability of practices. I think not applicable just reads wrongly. I think we should be making sure that communication and engagement with our public is important in every report that we come back, and any progress we've made for that. Certainly with my role as co-chair of the Tayside-wide contract implementation group, we're putting a lot of effort into working out how we can improve our communications and engagement plan around the contract specifically, but I think the wider primary care, that should always be a focus for us.
Thank you. Very valid point there, Andrew. Does anyone else want to come in there? No? We all okay? Good. Can I go back to the recommendations then? and with the change to recommendation 2, in that we will actually carry out or take part in a special board meeting next week in order to complete that action. I'm sure someone will manage to get the wording right for that. Are we happy to accept the recommendations in that paper? And thank you, Lisa, for your work there, and thank you to all who work in primary care. It's an invaluable, obviously, part of the system, and we do appreciate the challenges. Okay, so on to our workforce update now, which is item 13. And while Eunice makes her way to the table, I just want to say this: I found this a really good report. It was really helpful, Eunice, so thank you for that, and I look forward to hearing from you and the questions thereafter. Thanks.
Thank you, Chair. Good afternoon, everybody. And I have to say I'm delighted to bring this annual workforce update reflecting all the work of the staff in Angus Health and Social Care Partnership over the past year. And hopefully you can see from the content of this report, there's been a huge amount of work, effort, creativity, innovation, looking for solutions in what is quite challenging times in terms of the workforce. You'll see before you today there are a number of recommendations. I just want you to point out particularly numbers 5 and 6, which is around asking for a reasonable level of assurance regarding whistleblowing, and also then to get agreement about the frequency of reports coming to the IGB going forward. I think I would like to say that this report reflects the successes of a really strong team within Angus, which sits under the Workforce Steering Group chaired by myself. We have a number of subgroups which is highlighted throughout the papers, and there's a lot of commitment and dedication given to this area of work. I'd specifically like to thank Fiona Davidson, who is a recently retired service leader, long-standing employee of Angus Council and then within the partnership, who has led a lot of this work, and also to Morgan Lowe, who has ably taken over from Fiona on this agenda. You'll see within the cover paper in a lot more detail within the report a lot of the successes we've had, and I'm very proud of the work that we've done to try and address some of the challenges. We've spent a bit of time already today talking about unmet need, and we'll be talking further about that later on, I'm sure. But just this sort of creative work around attracting people into the social care workforce. And we all know the challenges around trying to do that, competing with other local businesses, supermarkets, etc. And we've actually been very successful. There's still a lot more work to be done, so we're certainly not complacent because it is an ongoing challenge, but we've done a lot of work around that. We're also focusing on the young people within Angus and trying to engage young people into coming to work in Angus Health and Social Care Partnership. And there's a lot of activity around that in terms of employment schemes. We've also focused on our Ukrainian workforce and trying to make sure that we can bring people that have come to live in Angus from Ukraine. And there's a lovely story within the report, which I hope you'll have noticed and read, about an individual that has come and contributing to life and work in Angus. Saying that, we've also got a lot of challenges, and we're not scared to highlight them, and there are a number of challenges around that. Again, we're not downhearted. We continue to come up with ideas, and I think one of the real benefits of the workforce plan and the steering groups is we share ideas across the partnership. So what works well in one area, we'll try and replicate in another service area, and I think that's really been quite successful, and we try and work very much collaboratively as a team. This year, since our last plan, there's been the implementation of the Health and Care Staffing Scotland Act 2019, which came into place on the 1st of April this year. We have a subgroup that sits looking at that in particular, and it reports through to the Workforce Steering Group. There's a lot of work and effort been done to make sure that we are providing safe staffing across our health services and also our social care services. And just on Monday, we were looking at our Q2 submission to NHS Tayside Safer Staffing Board, and we're able to offer a reasonable level of assurance that we are making really good progress in this area, despite a lot of challenges we have around the workforce. But patient safety and the needs of our service users are obviously a top priority for us. So I'd just like to thank everybody that's been involved in this work over the past year, and I'm happy to take any questions. Thank you.
Super, thanks, Eunice. I loved Ludmilla's story. It's really nice to see that. Any questions? Andrew, you look poised. No? Okay. Anyone else? No? Gosh, you've shocked them into silence.
Short and sweet.
Seriously, Eunice, I did appreciate that report. It was really helpful, and it represents, I know, a huge amount of work. So thank you for that. I really do welcome it. So just let me get back to page 106, which has the recommendations on it. So we're specifically being asked to accept a reasonable level of assurance with regards to whistleblowing. I'm feeling very comfortable about that for sure, and agree to the frequency of assurance reports to come to the IGB, and I think that's an annual basis, and the whistleblowing reports will be contained within that. Is everyone happy with that? And that links back to the conversation around the work plan and keeping things manageable for everyone. Thank you. So that's us accepted all those recommendations. Well done, Eunice. And item 14, our lead partner services update, and that's over to Jill.
Thank you, Chair. So this is the first time we've brought a lead partner services update paper to the IJB. We felt it was important that the IJB had a level of sightedness on the services that we have lead partner responsibilities for, which are detailed in the paper, and those are the Tayside GP out of our service, speech and language therapy, Tayside continence advisory and treatment service, and forensic and custody healthcare service. We also have a role around the strategic coordination for primary care, which is included in the report. The report just gives a level of detail around some of the issues that we've been talking about before around demand and capacity, particularly on the services where they do have and see an increase in waiting times around their clinic times, but also the demand from a GP out of hours service perspective, and that links with the paper that we saw on urgent and unscheduled care, and also has links to the primary care paper also. I think just to draw members' attention to a couple of specific areas within the paper on page 169 regarding the strategic coordination for primary care. Members may remember the plan on the page that we did bring to the IJB, I think last year possibly, and it just details where we are currently in relation to developing a specific strategy document for primary care. We've also strengthened the governance arrangements around lead partner services, and for those members that are on audit committee, the action plan that is quite extensive on that will recall that the governance of lead partner services is included on that. Across all three partnership areas, we have done a lot of work to try and improve that from a quality perspective, and also sharing the financial position across. So we do have an established process in place now to share reports around care clinical professional governance, the annual quality assurance reports, and the financial element of that. And my intention would be to share this report with Dundee and Perth, Perth and Kinross integration joint boards, to allow them to have a level of sightedness on the lead partner services out with their areas. I don't think I'm going to go into any more detail. I think happy to take questions, and also happy to take feedback on content, given it's the first time that we've brought a report in this way.
Thank you, Jill. And I mean, I hear what you're saying about sharing this with the other two IGBs. Will we get reciprocal information? That's the plan. I had raised this before, so I just wanted confirmation of that and assurance for you that you'll get that. So any questions? You'll see that it's a really interesting arrangement, and it has been challenging, I think it's fair to say, over various topics, but I feel that we're getting to a place where people are understanding how it works and the strategic position and the more operational aspects in each of the IGBs that allows it to be a much smoother functioning process. Does that seem reasonable? Okay. Any questions on that for Jill? No? Okay. So if we can scoop to the recommendations on page 164. Oh, sorry, Lois. You've dipped below the horizon down there.
Sorry, I thought you were going to then go on to comments, sorry, and it is just a very quick comment, and it's just to say that kind of welcome some of the reports that have been brought today. I think they're different to what we've, I think, first time for some of them. So it was really just to say I didn't have any specific questions on this report, but I did welcome coming it so that I could see, like you've said, just it goes into a little bit more depth and detail of the range of work that goes on. Thank you.
Thank you, and I think everyone knows, but I'm pretty relaxed about questions and comments. I don't segregate them, so that's perfectly fine. Okay, so going back to the recommendations again, there are 3 there around acknowledging the current position of various services, acknowledge the improved reporting and governance arrangements, which I think we've done adequately as well, and request that a further report comes to the all IGBs for approval in December this year and February next year. I think we'll all be happy with that. Yep. Thank you very much indeed. And we're moving on now to the risk appetite paper, and Abigail's going to do it. Get your Sunday name, Abigail. Abby, thank you.
Thank you. So I just want to draw your attention to Appendix 1 of this report that outlines the updated risk appetite statement for the IJB. Risk appetite is defined as the amount of risk that an organisation is willing to seek or accept in the pursuit of its long-term goals. By developing a risk appetite, we're setting clear boundaries to help guide decision-making. And I think this approach is especially valuable at the minute as we balance multiple priorities and recognise that taking some risks can be necessary for progress. Agreeing a risk appetite helps members weigh the potential upsides and downsides of any decisions and make sure that as an organisation we're not only avoiding unnecessary risks but also not missing out opportunities that align with our strategic goals, but with that acceptance that we may need to accept some risks to take advantage of those opportunities. Once we've agreed the risk appetite statement, the next step is then to really consider how we apply this to our decision making in practice. So for example, in the types of decisions that may come to future IJBs. Applying the risk appetite, it requires a consistent approach about when to take risks and when to be cautious. And I think this is an area that across Tayside and across Scotland, that we're all kind of in that infancy stages of in terms of that application. Recommendation 3 within the paper asks members to support a development session to consider, discuss and agree how you may wish to implement this risk appetite to support and guide that decision-making process. And just to note that it probably won't require a full development session, and perhaps we could maybe merge this in to another development session in the next year. But I'm happy to take any questions and any feedback in the process in terms of how we gathered the feedback around this year, because we did do it a little bit differently through MS Forms. Thank you.
Thank you, Abby. And I think, I mean, the Audit Committee was pretty quick off the mark in terms of doing risk appetite previously, so I think it's really helpful to keep it pretty high on the agenda. Any questions? Yes, Andrew.
Yeah, thanks to Abby for that report. Yes, I think possibly we should. I'm not conscious that we do apply our risk appetite. Having developed it, only once ever heard somebody saying, oh, our risk appetite for this is high, therefore this decision is supported. I think there should be a section in every report saying, you know, like we have equality impact, there should be a risk impact thing in there as well. Should take that into consideration when we make approved recommendations and decisions. Thank you.
Jill's going to come in there.
I think, Andrew, good question, and I think in section 8 of all of the reports, the risk management section, what we are trying to do is bring a consistent approach to the completion of that. So you will see that some reports have an approval recommendation, and what we're trying to do is get a consistent way of saying that this is within our risk appetite, so that we can demonstrate how we are using our risk appetite to guide some of our strategic decision making.
Thank you. Anyone else on this particular paper? You okay there, George? Okay. Okay, that's marvellous. I absolutely support a development session or part of a development session on this, and I think it would be good if officers linked it into something compatible that makes sense. I think that would be really good. And the online development sessions that we've had have been really helpful. I've found that. Sorry, there's some sign language going on here. Am I all right? Okay, that's fine. So can we approve the recommendations on page 174, the third of which is around the development session, but endorsing the statement being reviewed and updated every 2 years? Does that feel like a reasonable timescale? Because it is quite a significant piece of work. And I think we're flexible enough to escalate anything in the interim if we feel that's required. We did a sign language contribution on Friday at a development session because Sam and I lost audio. So that was helpful. It was. Okay, so thank you very much for that. And we move now on to the Category 1 responder. And Abby, thank you very much for talking to the paper today.
Thank you. Let me just get to my up. So quite excited to bring this update around the Category 1 responder and resilience planning progress. So we've done quite a lot of work over the last year, and as it's been noted earlier, you know, we've just reached the anniversary of Storm Babette, and it's still quite fresh for all of us, and some of the work that we've progressed over the last year has been as a result of learning from Storm Babette. So the report in front of you explains our role, or the IJB's role, as a Category 1 responder in emergencies under the Civil Contingencies Act, and it outlines what the IJB is responsible for and how ready Angus Health and Social Care Partnership is, along with our partners, to handle emergencies efficiently. We developed a resilience planning framework for the partnership. This can be found in Appendix 1 of the report, and this serves as a single reference document outlining Angus Health and Social Care Partnership's approach to planning, responding to and recovering from incidents affecting health and social care services in Angus. It's built on the principles of good governance, and each section of the document focuses on specific areas of resilience. The framework covers all Angus Health and Social Care Partnership services and outlines roles and responsibilities and actions for individual services and the wider Angus Health and Social Care Partnership management. It ensures that we can plan, respond and recover from incidents impacting Angus communities whilst maintaining critical activities during an incident. We've established an Angus Health and Social Care Partnership Resilience Planning Group with the aim of ensuring that the HSCP supports compliance with the duties outlined in the Civil Contingencies Act. This group will seek to provide assurance to the IJB through Angus Health and Social Care Partnerships Clinical Care and Professional Governance Group and Angus IJB Audit Committee, and this assurance will cover the effectiveness of processes in place to ensure that we respond efficiently and effectively. I hope everybody's had an opportunity to read the framework, and I'm happy to take any questions.
Abby, thank you very much. And I mean, these incidents, and including the pandemic, are so still vivid in our lives that we know this works You know, we know things swing into action. We know people know their part that they're playing in that, and I've highlighting to myself the importance of the psychosocial response, because we're all still living through the impacts of the pandemic, and I think still people don't fully realise the impact it's had on themselves, far less on a population level. We're going to be experiencing that for a very long time, so it's really good to see that recognised in the paper. Does anyone have any questions? Right, Martin was marginally ahead of Sam there, so get in there.
Thanks, Chair. Just clarification, who would be the Category 1 responder within that? Because this is an integration joint board, and then you've got a health and social care partnership that has 2 partner bodies.
So essentially the IJB is the Category 1 responder, not the Health and Social Care Partnership, which is why we need an IJB resilience framework.
Abigail, just reading about the exercising of plans, because I can think back to my service days, that if you had a plan, you had to exercise it, and you say that all staff have a role in responding, should participate in these exercises. Is there a mechanism to make sure the staff undertake that, or is it a voluntary commitment?
So the expectation is that all services will undertake a test and review of their BCP on an annual basis. So we have just set up a rolling programme within the partnership to review all BCPs using a sort of quality checklist to make sure that we have a consistent approach to this. And part of that is evidencing their annual exercising of the plan.
Thank you. Obviously, these plans do have a military basis. It's quite obvious, isn't it? Yes. So thank you for that. Anyone else have any questions there for Abby? I think it's a really comprehensive plan. I have a huge amount of comfort from it, and we've all still got the scars on our backs, really, haven't we? So thank you very much, Abby. I'm happy, I think, that we can all accept the recommendations on page 180 as highlighted in the report. So thank you very much. Okay. And we're then going on to communication engagement update, which will be Sally Wilson. Sally's just coming up, which gives me time to find the page. I'm so getting there. Thank you. Thanks, Sally.
Thank you very much, Chair, and thank you for the opportunity to provide an overview of the activities that have been taking place over the last year in relation to communication and engagement. So members will be aware that since the last update in October last year, reports have, where relevant, included a communication and engagement section, just to make sure that members are informed about any activities that are taking place and to support with decision making. So I haven't gone into great detail about all the different activities that have taken place where papers have included activities. So I've included reference to care opinion, and we've mentioned that again today. But I'd just like to let members know that we have now reached over 4,000 stories that have been collected in care opinion. So really, really pleased with that. And really, oh, sorry, it's 4,400, not 4,000. But I was getting over ambitious. 400 stories. So, but they are read many, many times by people, and it really does emphasise the great work, and the majority of them are positive stories. So really, really delighted, and really encourage anybody listening to the IJB today that please do share your stories, and because it means such a lot to staff when they receive your feedback. I was delighted that we continued our TV presence. We had a media release last year, or we featured on STV in relation to nature prescribing, but we continued with our presence on TV in relation to the Are You OK campaign, which is such an important campaign for Angus. And we were delighted that STV really picked up on that story, as well as Radio Tay, and thank you for Julie to featuring in that. We have had a number of podcasts, and the report details those, and with a varied listening audience, but really delighted that we're building on the podcasts, and we have a podcast planned very soon around future care planning or planning for the future. And while conversations were taking place today, I actually thought it might be a good idea to raise awareness of the AMPs in primary care and the work that the OTs are doing. We're currently collecting feedback about how people are accessing services. That isn't included in this paper. It was, I just thought members would like to know, and we will be able, maybe through Jill's Chief Officer report, be able to provide some feedback about that. And lastly, I thought that IGB members would be interested to learn, and again, I only learnt about this earlier in the week, that the Service Manager for Community Mental Health Services and other members of the team have been asked to speak to members of the Scottish Government on the 12th of November to share the great work that's taking place across Angus in relation to mental health and wellbeing and suicide prevention. So that's a really, the word is getting round about the great work that's taking place. So this will be an opportunity to highlight what's going on in Angus and to strengthen the links between community-based primary care and secondary mental health service. So just really, really delighted about that. So any questions, be delighted to answer them.
Thank you very much, Sally. Anyone have any questions? Andrew first.
Yes, it's Appendix 2. I just recently become a convert to these podcasts, and I'm sort of looking up all the back copies and that. They're actually very professionally produced. I find them very entertaining. I'm quite hooked on them now. Can't wait for them. Can't wait for the next one. And so my question was actually, you've got metrics or analytics is the word on total listens. Have you got a breakdown of how much is staff and how much is public?
No, we're not able to break that down, unfortunately. It's just the analytics is just how many people have listened. But we do ask around, and it does seem to be quite varied because, for example, the podcast that Jill did when she came into post, a number of staff members said that they had listened to that. So unfortunately, I don't know whether it's going to be possible to get that. I think my feeling is that no, we won't be able to have that breakdown, unfortunately. But thank you for being so encouraging about them. Any suggestions for future topics? We'd be delighted to have that. Consider that.
So if you've listened to them all 6 times, that'll be impacting the staff. But we're just thinking, if you want to do a podcast on the audit committee, speak to Sally. So as someone who used to work in radio, it was actually really nice to be on the receiving end of Sally's interviewing technique. She's very gentle. So I would encourage anyone, if they've got a topic that they want to pick up with Sally that hasn't been covered, then please do and go away and listen to the other ones. A couple of things before I open up to questions. I see Lewis's hand. Was maybe around not wanting to be a Debbie Downer, but picking up at some of the social media spread would be, I think, would be good to see and make more use of that, because the number of followers doesn't seem to match up to awareness around other areas, and also that engagement around offline in real life in person. Which is obviously really important, and having that face-to-face presence in order to connect with people who maybe aren't online. But over to Lois now.
Yeah, thanks. Just kind of following on from that, Julie, I recently brought a motion to Angus Council in support of Age UK's offline and overlooked campaign, which was, just as you touched on, Sally, about the difficulties and barriers, particularly older people, but not exclusively older people, but that just difficulties for those that are not online, that don't have the internet, and the difficulties they have accessing services. and being kept up to date with information. So in the UK, 2.3 million people aged 65 and over do not use the internet. So that's, I think, around 1 in 5. 4.7 million people aged 65 and over don't have basic skills to use the internet, and around 3.3 million aged over 65 in the UK don't use a smartphone. And we know that kind of a lot of the kind of things that, you know, is out there online can only really be accessed through using a smartphone. So it would be really good if, like, the partnership could kind of take that on board. And I think, as Julie said, just make sure that our engagement isn't just online, that we do have face-to-face opportunities. And I did look through the report, and apologies if I did miss it, and it is in there, but yeah, I didn't really see any reference to that. And I know that, you know, you can't put everything into a report, and it doesn't always capture all the work that's going on, but it would be good that we don't lose sight of that, and that, you know, we keep that in there as a sharp focus of engagement.
Just to provide some reassurance, Lois, we've got some ongoing work at the moment in relation to loneliness and social isolation, and we have an NHS management trainee working with us in Angus who is actively going out and about speaking to people about social connectiveness, because I'm very aware that we didn't want to do this just online. We will be using the Angus Council Engage platform, but we will be inviting people, if they prefer, to speak to somebody on the telephone or have a paper copy, or our management trainee, Katie, is going out and about. So we will be sharing a copy of that. But I'm a real stickler. If people are doing online engagement, I insist on there is an opportunity for people to telephone in. We can't go out and about all the time, but we do try, and we're proportionate in the way that we engage with people. And the way we're collecting feedback about accessing services is through the telephone. But thank you.
Thank you very much. And any more? I'm not seeing any more. Okay. So thank you very much. And recommendations on page 209. We've scrutinised and discussed. We'll get more reports as per the work plan, and in the middle there is a reasonable level of assurance appropriate. Is everyone comfortable with that? Definitely. So thank you very much, Sally. That's great. We're on the home stretch. Sorry? Who is Eunice? Sorry. Eunice, you're covering the next paper, please. That's Social Care Procurement and Commissioning Service Development Plan. We're getting there.
Thank you. So I'm pleased to bring this report on behalf of my colleague John Cooper, who is leading this area of work and who's not able to be with us today. So this is the first report of this type coming to the IGB, and it's to provide an update on planned procurement of social care and planned commissions developments for 24-25. You will see in the paper, which I'm sure you've all read, is that the Health and Social Care Partnership are responsible for commissioning a very significant amount of services. So over the past few months, a group chaired by John Cooper has reviewed all grants and contracts and been developing and embedding best practice in making sure that, in line with good procurement practices, we have good, strong contract oversight. We're holding our providers accountable for good quality care that they are responsible for delivering. As part of the work and looking at all the grants and contracts, a small number of non-statutory and non-direct care delivery contracts have been ceased, which has helped to provide a saving of £180,000, which is 10% of our overall spend, and that had been highlighted in a previous financial report. Going forward, we are undertaking work to revamp and redevelopment our market facilitation statements, and the proposal is to bring back the development plan in April 2025, which will provide more details. I'm happy to take any questions. Thank you.
This seems pretty straightforward to me. Does anyone have any questions? No. I think we really need to approve and support this as highlighted in the recommendations. So thank you very much, and thanks to John for the work. I know he'll be you know, a bit miffed he wasn't able to be here today. But thank you very much. So happy to approve all 4 recommendations there. So Jill wants to come in next before we cover off the final item.
Thank you, Chair. I just wanted to extend my thanks. I didn't say thanks in every single report to individuals across the partnership who have supported bringing the papers, but thanks to everybody sitting across there and members of the team who have worked really hard to get 18 reports to the IGB, and thanks to IGB members for enduring an 18 or 19 agenda for October. It has been quite a challenge, but an enormous amount of work from colleagues in the partnership to be able to bring the papers for today. So I just wanted to extend my thanks to everybody.
I absolutely endorse that, and at pre-agenda we were aware of how big the agenda was, but I hope people feel that we've done your papers justice in terms of scrutiny and engagement in there, because they're really well written, they're well presented, and they're directly meaningful to the services that we deliver. So I am grateful for that. So just before we go on to the date of the next 2 meetings, I just wanted to recognise that today is the last meeting that George Meakin will be here, and to thank George for his contributions since May 2022, was it? And we look forward as well to welcoming George's replacement, and wish George the best in his other roles going forward. So thanks, George. Okay, so finally, next meeting, the special meeting on November the 7th at 9 AM. If you can check your emails for that, please. And then the next planned meeting is Wednesday, the 18th of December at 2 o'clock, and I look forward to seeing you then. Thank you for your contributions today. It's very much appreciated. And thank you to everyone online as well. Take care.
John, can we stop the live stream, please?